Hello student, now we are going to discuss lung volumes and capacities. So all of you know that most of the lung volumes and capacities are measured with the help of an instrument, and that is spirometer. So first look at how spirometer works, right? So it consists of a drum. This drum is invertedly placed on the surface of a water chamber. So this is the drum which is placed invertedly over this water. So what will happen? The drum will float on the surface of this water. That's why this is known as floating drum. Inside this drum, there will be air, normal atmospheric air will be present, or you can fill this drum with oxygen also. That's why it is written that this is oxygen chamber or normal air chamber. Whenever we record normal spirometry, we generally use the normal atmospheric air only rather than pure oxygen. Now next thing you have to note down is that at the center of this drum, one tube is fitted. This tube, if you follow this tube is ultimately connected at the mouth of the subject. That's why it is written that this is the mouthpiece. So the subject has to take this mouthpiece inside the mouth, and then the nose will be closed. After closing the nose, if the subject is taking inspiration or expiration, so suppose the subject is taking inspiration or the subject is doing expiration, what will happen? Both the inspiration and expiration that will occur inside a closed space, means both this inspiratory air will be coming from this air which is present inside this drum, and whenever the subject will expire, the air will also go inside this drum only. So that's why it's a closed system, right? Now we look at whenever the subject is doing inspiration or expiration, the drum will move up or down. See, if the subject is doing inspiration, what will happen? The subject is using the air from this drum, so the volume of the drum will be decreasing and the drum will move in the downward direction. But look at, if the drum is moving in the downward direction, what will happen to the movement of this writing pen which is connected in this system? You can find out here the drum is connected with this writing pen in such a way with the help of these pulleys that whenever the drum is moving in the downward direction, the pen is going to move in the upward direction. That means I can understand that inspiratory effort will be recorded in the upward direction in the conventional spirometer. So where this pen is going to write? The pen is going to write on a recording chart paper, and that chart paper is again connected on the surface of another drum. This drum will move on a constant speed, and when the pen is moving up and down, the recording will be clearly visible on the surface of this chart paper, right? So this way, if you look at then expiration, suppose the subject is doing expiration, so what will happen? Some extra air is going to enter inside this drum, so the drum will move in the upward direction. If the drum is moving in the upward direction, then ultimately the pen is going to move in the downward direction. So the bottom line of our understanding is that upward movement of spirometer recording means inspiratory recording, downward movement means expiratory recording. So similarly, if you look at another picture, okay, another diagram I have kept here so that it becomes easier for you to understand. So here you can find out that the subject is expiring. So the expiratory air is entering inside this drum. The drum is moving in the upward direction. Because of the movement of the drum in upward direction, the writing pen will move in the downward direction. So that's why you can find out in this recording that expiration means the recording will move in the downward direction, and inspiration means the recording will move in the upward direction. This is the conventional spirometer. Now we are going to discuss that how the recording looks at the level of spirometer, normal recording, how it looks at the level of spirometer chart. So before that, you know that lung volumes and capacities, whenever we discuss, you have to remember that lung volumes and capacities are of two types. One is known as the static lung volumes and capacities, and another one is dynamic lung volumes and capacities. You know that whenever we are saying static lung volumes and capacities, we measure only the volume. Only the volume recording is done without the recording of time, right? But whenever you are recording lung volumes with respect to time, so volume per unit time, then that kind of recording is known as dynamic lung volumes and capacities recording, right? So the unit of the static lung volumes and capacities will be in ml or will be in liter, and here it will be ml per second or ml per minute or liter per minute, like this. So this is the difference between static and dynamic lung volumes and capacities. So first we are going to discuss how the static recording looks like at the level of spirometer, right? So to discuss this, I am drawing one diagram first. So this is the y-axis. I told you that y-axis is going to record the volume. This is the volume axis, and x-axis will be the time axis, but because it is a static recording, we are not going to calculate the time here. So this is the starting point of the maneuver. Suppose this is the starting point of the maneuver. First you instruct the subject to take few normal breathe in and breathe out. Normal inspiration, expiration. So whenever the subject is taking normal inspiration, the curve will move in the upward direction, and when the subject is doing expiration, the curve will move in the downward direction, like this. So the subject is taking inspiration, expiration, inspiration, expiration, few normal breathing. Now you are asking the subject to take a deep inspiration. So whenever the subject is taking deep inspiration, the curve will move in the upward direction, and then you ask the subject to do a forceful and maximum expiration as maximum as possible. So the curve is going in the downward direction, like this. So this is the maximum expiratory point, and then you ask the subject come back to the normal maneuver and end the recording. So now in this recording, you can find out that when the subject is taking normal breathe in or breathe out, he is using certain amount of volume. Okay, if I want to measure that volume, so I have to take this upper part of this recording and this bottom part of this recording during normal breathing. If I calculate this volume, this is nothing but the tidal volume. So we know that tidal volume means it is the normal volume which is entering inside your lung or going out of your lung during normal breathing, right? So this is the volume which is entering or going out during normal breathing. Normally the tidal volume is approximately 500 ml. So you can easily find out from this marking on this y-axis. Okay, so suppose this is 2300 ml, okay, and this is 2800 ml. So easily you can find out that the tidal volume from this spirometry recording is nothing but 500 ml, that is normal. Now if I want to measure that how much extra amount of air the subject is breathe in during maximum inspiratory effort, extra amount of air, extra above the normal amount. So this is the normal part. So if I measure the extra amount of air that is entering in the system during maximum inspiratory effort, this is known as inspiratory reserve volume. So this volume normally remain reserve in your lung. You can use this reserve whenever there is requirement. Suppose you are doing exercise, so you require more amount of breath, more amount of oxygen. So what will you do? You will do like this, hyperventilation. Then we generally use this reserve. That's why this is known as inspiratory reserve volume. Normally this is 2 to 3 liter. So I'm writing here 2000 ml is the normal volume, right? So this will be around 4800 ml on your y-axis reading. From this y-axis you can easily calculate this extra volume that the subject can take in, right? Now similarly, if I calculate how much extra amount of air the subject is expiring during forceful expiration, right? So what will happen? I have to find out this volume, okay, from the normal up to this forceful expiration. This will be known as expiratory reserve volume, ERV, expiratory reserve volume. So expiratory reserve volume normally, this is 1000 ml or 1 liter, right? So expiratory reserve volume is similar to the inspiratory reserve volume. It is there inside your lung as a reserve. Whenever you require during hyperventilation, it can be utilized, right? Now, even after recording this TB, IRV and ERV, you know that another volume will still remain inside your lung, which you cannot measure with the help of a spirometer, right? So that volume which is still there inside the lung, here it will be here, okay. I cannot measure this volume with the help of this spirometer. This volume is known as residual volume. You are not going to get the recording of the residual volume on spirometer, but if you know that this is my 0 point, okay, then you know that normal residual volume is approximately 1300 ml. So what is the normal residual volume? That is 1300 ml. But you are not recording this residual volume with the help of an spirometer. So question will obviously arise that how to measure the residual volume. Is there any other maneuver? Is there any other method? Answer is yes. So please note down that residual volume measurement is done by 3 methods. You have to remember all these 3 names. Number 1, helium dilution method, right? This is the most common method for measuring the residual volume of the lung. The second method is nitrogen wash out method. You must have heard this method in the previous discussion also. But previously we discussed single breath nitrogen washout method. If you have to measure the residual volume, remember it is known as multiple breath nitrogen washout method. Means subject has to breathe in and out inside a closed chamber. Okay, and that's why this is known as multiple breath. Breathe in and out multiple times. That's why this is multiple breath nitrogen washout method. And the third method is known as body plethysmography. So this body plethysmography is the best method for measuring the residual volume of lung. So although we are saying that there are 3 methods for residual volume measurement: helium dilution method, nitrogen washout method and whole body plethysmography method. But if I ask you which one is the best method for measuring the residual volume, your answer body plethysmography. But the most common method, commonly used method is this one, that is the helium dilution method, right? So now these 4 lung volumes, okay, this IRV, okay, this IRV, then your TB, then your ERV and this residual volume. These are nothing but static lung volumes. Now all of you know that if you calculate the capacities, lung capacities, okay, so capacities are nothing but it is combination of multiple lung volumes, right? So all of you know that if you add up this tidal volume plus inspiratory reserve volume, this is known as inspiratory capacity of the lung, right? Simply you can add up 500 plus 2000 ml, that will be your inspiratory capacity. Then if you add up this tidal volume plus IRV plus expiratory reserve volume, combination of these 3 volumes is known as vital capacity or VC, right? If you combine only the residual volume plus your expiratory reserve volume, this is known as functional residual capacities. We have discussed this functional residual capacities multiple times. This is known as the resting lung volumes, resting capacities of the lung. That is nothing but RV plus ERV. And if you combine all these 4 lung volumes, right, for example, residual volume plus ERV plus TV plus IRV, that is nothing but known as total lung capacities, right? So these are the different capacities, okay, static, lung volumes and capacities that we have discussed so far. But apart from all these capacities, you have to understand another important one, and that is known as the closing capacities of the lung. Closing capacity of the lung, right? So this is very, very important for your MCQ, because that this tidal volume, residual volume, they are there, but obviously this closing capacity is more important for your MCQ. So what is this closing capacity, right? You have to recall certain information which we have already discussed. You think of a person who is in upright posture and think of the resting condition of the lung, right? So tell me, the size of the alveoli is largest in which region of the lung? First you try to recall that, right? So I'm writing, or I'm drawing this diagram, okay? So this is the diagram of lung. I'm drawing one large alveoli at the apical region, okay? A smallest size alveoli at the middle part and the smallest size alveoli at the base of the lung. We have discussed this, that in resting condition, if the person is in upright posture, then the size of the alveoli is largest at the level of apex, right? So if the size of the alveoli is largest, you can also find out that these bronchioles which are attached or connected with this alveoli, their size will also be larger, okay? Similarly, the bronchioles of the basal alveoli, they will be smaller in diameter, right? Now, if I do a forceful expiration, right, so now I'm doing a forceful expiration, so I'm applying some forces from this chest wall, okay? Try to imagine yourself. So you have taken a deep inspiration and now you are doing a forceful expiration. So whenever you are doing a forceful expiration, what will happen? There will be decrease in the size of all of these alveoli gradually, because more and more air will go out of this lung. So what will happen? There will be decrease in size of this alveoli, okay? But as you can find out that whenever the air is going out of this lung, the alveolar size is decreasing, but because the basal alveoli are smaller in size, the diameter of the bronchioles of those alveoli will be very, 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 very small. Now, if you continue doing this forceful expiration, what will happen? At the end of this forceful expiration, what you will be finding out, that the alveoli at the basal part of the lung, the bronchioles of those alveoli will be completely closed. Look at. So if I draw this apical alveoli, it is still open, although the size has been reduced. This is the middle part alveoli. Its size is reduced, but it is still open. But if I look at the basal alveoli, then the bronchiolar diameter is so reduced that the alveoli is almost closed, right? Then if you continue doing this forceful expiration, what will happen? Ultimately, this middle part alveoli as well as this apical alveoli will be closed off, right? What I'm saying? So whenever you are doing forceful expiration, the closing of the alveoli, the closing of the bronchioles is starting from this base, but ultimately the middle part alveoli will also be closed. The apical alveoli will also be closed. After closure of all these alveoli, the remaining volume of air which is present inside all of these alveoli, that air is known as the residual volume of the lung. Getting my point? So when all alveoli are closed off, so I can write down a bottom line like this: all alveoli in the lung are closed off, right? In this condition, the remaining air inside lungs is known as my residual volume. Getting my point? So when all the alveoli are closed off by closure of the bronchioles. But where the closure has been started, the closure has been started at the level of basal alveoli because their size is smaller. But ultimately the middle part as well as the apical alveoli will be closed off, and when all are closed off, the remaining volume is residual volume. So I can easily understand that residual volume is always staying inside the lung. It is never going out of the lung, right? If it is not going out of the lung, obviously you will not be able to record at the level of spirometer, because I told you that spirometer record only those volume where the volume is entering inside the drum or the volume is going out of this drum. But residual volume, it is always remaining inside the lung, it is never going out, and that's why you are not going to get recording of this residual volume in the spirometer. Now, what is closing capacity then? So, I told you that closing of alveoli start at which level? The basal part of the alveoli, they are closed off first. So, I can imagine a scenario that if I do a forceful expiration, one condition will arise where the basal alveoli are closed off. Basal alveoli, it is closed off, but middle part alveoli are still open and apical alveoli are also open. In this condition, the remaining volume inside all of these alveoli will be known as closing capacity, closing capacity, closing capacity. So what is the definition of the closing capacity? So closing capacity, okay, is nothing but remaining volume in the lung when the basal alveoli are closed off. So it is nothing but remaining volume in lung when basal alveoli are closed off, right? So this is the volume which is remaining inside the lung when only the basal alveoli are closed off, but middle part and apical alveoli are still open. So obviously I can understand that if I continue doing this maneuver of forceful expiration, what will happen? This basal will be closed first, then the middle part, and then the apical will be closed, and then the remaining volume will be known as the residual volume. So what do you think? The closing capacity is more or residual volume is more? Obviously the closing capacity is more than that of the residual volume, because after the closing capacity, if you continue forceful expiration, some more air will go out of this lung from this middle part and apical alveoli, and then all the alveoli will be closed off, and that is known as the residual volume. So now we came to know that closing capacity means when only the basal alveoli are closed off, and residual volume means when all alveoli are closed off. So if you look at the previous recording, okay, this normal static lung volume and capacity is recording here, okay. So similar kind of recording if I draw to understand this closing capacity, so what will happen? The subject is taking inspiration, expiration, inspiration, expiration, then the subject is taking a deep inspiration, right? And now the subject is doing a forceful expiration. So during this forceful expiration, a point will arise, okay. So this is the expiratory part where only the basal alveoli are closed off. Basal alveoli, okay, are closed off. This point is known as the closing capacity. This point means the remaining which is there inside the lung. This is nothing but my closing capacity. But if the person continue to do this forceful expiration, he will expire some more volume, and then he will reach at the end of this expiration. At the end of this expiration, I can understand all alveoli, okay, all alveoli are closed off. During this condition, the remaining volume inside your lung is nothing but your residual volume. So obviously the residual volume is lesser than closing capacity, right? Generally we say that closing capacity is equal to residual volume plus another volume, that is you can find out here, and this volume is known as the closing volume. So basically if you want to calculate this closing volume, It is nothing but closing capacity minus your residual volume. Getting my point? So this is the way by which we know that we calculate the closing volume and closing capacities, right? So what is the importance of this closing capacity? Why you want to measure this closing capacity, right? Normally from this diagram I can easily find out that FRC. So FRC will be this one will be the FRC, because FRC is the combination of this residual volume plus ERV. So obviously in a normal person you can easily find out that FRC is always greater than that of this closing capacity. Okay, so I'm writing that for a normal adult person, okay, FRC is always greater than closing capacity, and FRC become almost equal to closing capacity at the age of 66 years. So I can easily understand that closing capacity gradually increases with progression of age, and when the subject is reaching at the age of 66 years, the FRC is almost equal to the closing capacity. But for a normal adult person, FRC is very greater than closing capacity. If you are finding out that for a subject closing capacity is greater than FRC, this indicate that the person is suffering from highly collapsible diseases of the lung, where the collapse of the bronchioles is very early. If the collapse is occurring easily early, then the closing capacity will be very higher than FRC. Means whenever the subject is doing this expiration, right, expiration is going on, and at this point the basal alveoli are starting closed up. So what will happen? Now I can find out that in this condition the closing capacity will be more than that of the FRC. That indicate that the lung is highly collapsible. Like for example, in case of children, the hyaline membrane disease, they will have this kind of finding. The closing capacity is very greater than FRC. So high closing capacity means highly collapsible disease of the lung. Now could you recall what is the method used for measuring this closing capacity? I told you during the discussion of the anatomical dead space that anatomical dead space is measured by a method which is nothing but single breath nitrogen washout method. This single breath nitrogen washout method is also known as FOWLER''S. This is also known as Fowler's method. I hope you recall this. So this Fowler's method or single breath nitrogen washout method is not only used for measuring the anatomical dead space, it is also used for measuring the closing capacity of the lung, right? So multiple breath nitrogen washout method is used for residual volume measurement, but single breath is used for measuring anatomical dead space as well as this closing capacity. Now if you could recall this method, okay, I am not going to discuss the detailed method here, you have to look back the previous chapter. So we had plotted a kind of graph like this, in single breath nitrogen washout method. So look at x-axis and y-axis, single breath nitrogen washout method. So what is done? The subject is inhaling pure oxygen first, and then you are asking the subject to do expiration. During expiration you are continuously measuring the nitrogen concentration in the expiratory air. So if this is the starting point of this maneuver, okay, initially the air will come out from the conducting zone which is already replaced by pure oxygen. That's why I told you that initial part of this recording where nitrogen concentration, this y-axis is the nitrogen concentration. Nitrogen concentration 0 means this is the air which is coming from the conducting zone, and this is nothing but anatomical dead space air. Then I told you that you will get a curve like this where the nitrogen concentration is rising, which is nothing but mixture of this conducting zone air as well as the alveolar air, and then you are going to get a plateau portion. This plateau portion indicate the air is coming from the alveolar region. So this is the pure alveolar region, pure alveolar air is coming, and then at the end of this maneuver you will be finding out suddenly there is an increase in nitrogen concentration once again. So this part where suddenly the nitrogen concentration start rising once again at the end of this maneuver, this point is nothing but closing capacity volume. So why the nitrogen is rising at the end of this expiration, right? So you know that in this maneuver, what I told, first the subject has to inhale pure oxygen. So suppose this is the lung and the subject is inhaling pure oxygen, right? When the pure oxygen is inhaled, this pure oxygen will replace this conducting zone air, and then some of the oxygen will enter in the alveolar region. So alveolar region means there will be mixture of air and oxygen, but this conducting zone means this is nothing but pure oxygen. So during expiration, if you measure the nitrogen concentration, the first part of the air which is coming from this conducting zone, nitrogen concentration is 0, and that is the dead space. Now when the air is coming from this alveolar region, there will be a fixed concentration of the nitrogen, and that is nothing but the plateau portion, that is the fixed concentration of nitrogen. That means the air is coming from this alveolar region. But suddenly at the end there is rising in nitrogen concentration. To understand this, again you have to look at this kind of diagram, that this is an alveoli from the apical region, this is alveoli from the middle part, and these are the alveoli from the basal part of the lung. When the person is taking inhalation of this pure oxygen, tell me, most of the oxygen will be delivered in which region of the lung? That means indirectly I am asking, ventilation is maximum in which part of the lung? All of you know that ventilation is more in the base of the lung. So this pure oxygen, when the subject is taking inhalation, most of this oxygen will be delivered at the base of the lung because ventilation is maximum there. So when the oxygen is going more in the base of the lung, I can understand that inside this alveoli, oxygen will dilute the nitrogen more. More dilution means what will happen to the concentration of nitrogen in this alveoli? It will be lower. But because the ventilation is less at the apical region, so less oxygen will be delivered in the apical region, there will be less dilution of the nitrogen. Less dilution of the nitrogen means what will happen to the concentration of nitrogen in the apical region? It will be more. That means I can understand that when the air is coming from this alveolar region, there will be a fixed concentration of nitrogen. But when the basal alveoli are closed off, air is coming from this apical region, what will happen to the nitrogen concentration? Nitrogen concentration will be more. That means whenever you are getting that sudden rise of nitrogen concentration in the expiratory air, that indicate that the basal alveoli are closed off and the air is coming from which part of the alveoli? This air is coming from upper part of alveoli, and upper part of alveoli contain more nitrogen concentration because of less dilution with oxygen. That's why we said that whenever sudden rise in nitrogen concentration is occurring, that indicate that the basal alveoli are closed up, right? And then when no nitrogen is reaching at the instrument, that means you have reached at the end of the maneuver, and end of the maneuver means all alveoli are closed and the volume which is remaining in the lung is nothing but your residual volume, right? So this way the single breath nitrogen washout method is giving you estimation of this closing capacity, although you can get an rough estimation of residual volume, but I told you residual volume is best measured with multiple breath nitrogen washout method, not by this single breath nitrogen washout method. So this is all about your static lung volumes and capacities, right? Now after static lung volumes and capacities, we are going to discuss the dynamic lung volumes and capacities, right? So to discuss the dynamic lung volumes and capacities, I am drawing this axis once again, x-axis and y-axis, right? So now I have to consider this measurement of time along with this measurement of volume in the conventional spirometer. So how this maneuver is done? First, look at, you instruct the subject to take few normal inspiration and expiration. So the subject is taking normal inspiration and expiration. Now you ask the subject to take a deep and maximum inspiration. So the subject is taking a deep and maximum inspiration as maximum as possible, right? So at the end of this maximum inspiration, the subject has reached up to the level of total lung capacity, right? Now you are asking the subject to hold his breath for a seconds, maybe 1 second, maybe 2 seconds. So when the subject is holding his breath, you will get a plateau like this, and then you note down the starting point of expiration. Now the subject has to expire. You have to instruct the subject that do a forceful expiration as forcefully as possible, as maximally as possible. These two instructions you have to clearly give to the subject, that do a forceful expression as forcefully as possible, as maximally as possible. So whenever the subject is doing a forceful expression, the curve will go in the downward direction, forceful expression is going on. So look at, the expression is going on, going on, going on, going on, going on, going on. This is the end of expression, and at the end of expression you stop the maneuver, right? So now what is my job? My job is to identify the starting point of this forceful and rapid expiration. So from this starting point, you drop one perpendicular on your x-axis. You drop one perpendicular on your x-axis, right? Okay. So just let me draw it clearly. So this is a perpendicular on your x-axis, and you also note down the ending point of this maneuver. So I can find out that this is the ending point of the maneuver. From this ending point, you drop another perpendicular on this y-axis. So this is the perpendicular on y-axis. So I can find out this intersection point between these two perpendicular. If I measure from this intersection point up to the end, then this is the total time the subject has taken for forceful complete expiration. I can say like this, right? So what do you think? How much time do you require for complete forceful expiration? How much time? At least you require 3 seconds. If you do like this, and then if you do a forceful expiration like this, you cannot do within 1 second. You cannot do within 2 seconds. At least you require 3 seconds. Genong is saying 3 to 6 seconds is required for complete forceful expiration, right? So suppose this is 3 seconds. So now I am dividing this 3 seconds into 3 parts. So this total time scale I am dividing into 3 parts. Now if I drop one perpendicular from this 1 second part on this curve, so I am dropping one perpendicular from this 1 second point. So this is 1 second point. From here I am dropping on perpendicular on this recording curve. So what you are finding out, that it is cutting the curve at a particular point. If I measure the volume from the beginning of this maneuver up to this 1 second point, then I can conclude that this is the volume the subject has expired within 1 second. And if I measure the complete volume from this beginning point up to this end, then this is the complete volume that the subject has expired during forceful maneuver, right? So this volume which the subject has expired forcefully and completely, this is known as the force vital capacity. So force vital capacity is nothing but a vital capacity only. If you calculate the volume, then it is nothing but vital capacity. Look at, okay. So what is vital capacity? Is tidal volume, inspiratory reserve volume and expiratory reserve volume. So if you do a forceful expiration, what is the total volume that you will be able to expire? That is vital capacity. So in this maneuver, if I ask you what is the total volume that you are going to expire, that is also vital capacity, but it is known here force vital capacity because the maneuver is done with two clear instructions, that you have to do a forceful expiration and you have to do a rapid expiration. So as forcefully as possible, as rapidly as possible. That's why this is known as forced vital capacity. Now within this forced vital capacity, so forced vital capacity, a particular volume, maybe 4 liter, maybe 5 liter, depending on different subject. Within this 4 liter or 5 liter forced vital capacity, I want to calculate that within 1 second how much volume the subject is expiring. This volume, if I measure, then it will be known as FeV1. That is nothing but forced vital capacity in 1 second, forced expiratory volume, FeV1. So F is forced expiratory volume in 1 second, and FVC is the total volume which is expired by the subject within 3 to 6 seconds. So FeV1 is total volume that the subject is expiring within 1 second. Similarly, if I drop one perpendicular from this 2 second point on this curve, and if I measure the total volume from this beginning up to the end of this maneuver, this will be known as FeV2, that is the forced expiratory volume in 2 seconds. That is the total volume which the subject is expiring within 2 seconds. And in these cases, this FVC will be almost equal to FeV3. That is nothing but total volume that the subject has expired within 3 seconds. So now note down, if this kind of curve is given in your exam, you have to calculate this FeV1, FeV2, FeV3, this with this kind of dropping of perpendicular and taking the value from y-axis. Now FeV1 and FVC, FeV2, FVC, all of them are separate volume. If I try to understand that FeV1 is how much percentage of the total volume, now I want to calculate that FeV1 is a separate volume, this volume is how much percentage of the total volume, then all of you know that this is 80% of the total volume, that is 80% of the FVC. That's why we say that if you take a ratio of FeV1 upon your FVC, this is nothing but 80%, and this ratio is very important. This is known as TIFFE NEAU, Tiffenau ratio or Tiffenau index, and this index is used for diagnosis of two different types of disease in the lung, that is obstructive disease and restrictive disease. So you have to remember that normal value of FeV1 upon FVC is 80%. Similarly, if you take a ratio of FeV2 upon FVC, then this is 95%, means FeV2 is 95% of the total volume, and FeV3 is almost 99 to 100% of FVC. So these three numbers you have to remember. This is a normal. FeV2 is 95% of the FVC, and FeV3 is 99 to 100% of the FVC. So I told you, among all these three, the FeV1 by FVC ratio, which is also known as Tiffenau index, this is very important because it will be helpful for diagnosis of respiratory diseases like obstructive and restrictive disease. So what is this obstructive disease and restrictive disease of the lung, right? Then we will discuss that how this dynamic lung volumes and capacities, if you record from this obstructive disease patient, how it will looks like. So obstructive disease means, remember like this, that obstruction during expiration, right? So if you look at the examples, okay, so the prototype examples of this disease is emphysema, right? This is bronchitis, emphysema and bronchitis, right? Not only that, asthma is also under this category of obstructive disease, and sometimes bronchiectasis. Bronchiectasis is also placed in the obstructive category of lung disorder. So in emphysema, what is going to happen and how these lung volumes and capacities is going to change, we are going to discuss this, because this emphysema is the prototype of the obstructive disease. Now if you look at the restrictive disease of the lung, okay, restrictive disease means, remember like this, restriction during inspiration. So if you are trying to take a deep inspiration, there will be some kind of restriction which will not allow your lung to expand completely. That is a restrictive disease. If I give you some example, so restriction can occur at the level of lung parenchyma. So that is parenchymal restriction, like for example fibrosis of the lung, maybe pulmonary edema. These are under the category of parenchymal restriction. The restriction can occur also at the level of pleura, like for example pleural effusion, right, or pneumothorax. It can also occur at the level of muscles, right, like for example if your muscles are paralysis, like for example myasthenia gravis, then also it is under the category of restrictive disease. Or it can also occur at the level of bones which are present at the level of chest wall. Like for example, if the person is suffering from ankylosing spondylitis or kyphocoliosis, then also the person will not be able to expand his lung properly. Like for example, suppose there is an bending of the spine, so will the subject will be able to expand his lung completely like a normal person? Answer is no. So that's why this is also under the category of restrictive disease. So I can understand that restrictive disease broadly is the parenchymal restriction and extra parenchymal restriction. That's why we say that restrictive disease means parenchymal restriction as well as extra parenchymal restriction. Okay, extra parenchymal means it may be at the level of pleura, it may be at the level of muscles, or it may be at the level of bones which are there on the chest wall. Now we are going to understand that how these lung volumes and capacities is going to change in case of obstructive disease first, and then we will discuss how it will change in the restrictive disease. Okay, so emphysema and how it is changing your lung volumes and capacities. To understand this phenomena, first of all you have to understand a normal phenomena that is known as dynamic compression of airways. That is known as dynamic compression of airways. Okay, so this is a normal phenomena which happens in normal lung also. In our normal lung also, when it is going to happen, when the person is doing a forceful expiration, and that is forceful expiration, right? So suppose one normal person is doing a forceful expiration, what is happening inside his lung, that we are going to discuss. Okay, so this is an alveolus. Okay, I am drawing. So the subject has taken a deep inspiration. Okay, we all know that these alveolus are lined by elastic tissues, and this elastic tissue has a tendency to recoil in the inward direction. We all know. Okay, so there will be inward recoiling. So this elastic tissue recoiling is very helpful for passive expiration, right? So if you take an inspiration and then if you release this alveoli, it will easily recoil back and the expiration will happen. So if I want to understand that what is the elastic recoiling force, so there will be a value. So suppose the elastic recoiling force of this alveoli is 5 millimeter of mercury. Okay, and you are applying an external force from this chest wall during this forceful expiration, and that forces that you are applying from this chest wall is 25 millimeter of mercury. 25 millimeter of mercury, that is the external force you are applying on this lung from chest wall. So what is happening? You have taken a deep inspiration and now you are doing a forceful expiration. During forceful expiration, you are applying some forces from chest wall. What is that forces? For our discussion, I am taking that this is 25 millimeter of mercury, right? This is 25 millimeter of mercury. And what is the elastic recoiling force? That is the inherent force of this lung, that is 5 millimeter of mercury. So what is the total amount of force that will be present inside this alveoli? That is nothing but 30 millimeter of mercury. So this 30 millimeter of mercury force means plus 30 means it is more than atmospheric pressure, right? 30 millimeter of mercury, that is more than atmospheric pressure. So what will happen? This will push the air out of this lung. It will push the air out of this lung. So air will continue to go out of this lung, and when the air is going out of this lung, what will happen to the size of this alveoli? We all know that gradually the size of the alveoli will be reducing like this. The size of the alveoli will be reducing like this gradually. More and more expression means more and more decrease in size of this alveoli. So now if you look at the end of this maneuver, so suppose now I have reached at the end of this maneuver, getting my point? Okay, so you are doing this forceful expression, inside the lung your alveoli are getting smaller, and now you have reached at the end of the expression. So size of the alveoli is smaller. What do you think? At this condition, this elastic recoiling force will be more or less than that of the previous one? Very simple. If you stretch a balloon, if you stretch more, it will try to recoil back with more amount of force, and if you stretch less, then recoil amount of force will also be lesser. So in this condition, suppose the elastic recoiling force is reduced to 1 millimeter of mercury, and you are continuing this external force from this chest wall. How much is the external force you are applying? You are applying this constant force of 25 millimeter of mercury from this chest wall. So what is the total force at the end of this maneuver inside this alveoli? 26. So this 26 force will also try to expel the air from the alveoli, but whenever the air is going through these bronchioles and bronchi, the pressure will start dropping down. Why the pressure will drop down? Because of the airway resistance. So more and more air is moving, this pressure will drop down more and more, right? Look at this number, 24.5, then 24, and it will go on reducing towards the mouth of this subject. So why this pressure is reducing? Because of the airways resistance. So with the help of this 26 pressure, the air is trying to go out of this lung, but during this journey, the pressure inside these bronchioles is dropping constantly due to airway resistance. So I can understand the external force that you are applying, this external force will also be applied at the level of this bronchi and bronchiole, because the whole chest wall is pushing the lung. So obviously the force is also going to be applied at the level of bronchioles. Now we look at the end of this maneuver, you have reached a point where inside the pressure, means pressure inside the bronchioles, is equal to the external pressure. Getting my point? External pressure is the constant pressure which is applied from the chest wall, and now if I look at the inside pressure of this bronchiole, one point I am getting where the pressure inside the bronchioles is equal to the pressure outside. This point is known as equal pressure point. Very, very important. This is known as equal pressure point, right? Now just beyond this equal pressure point, if I look at here, the pressure inside the bronchioles is 24.5, outside pressure is 25 millimeter of mercury. What is going to happen at this junction? I can easily understand that here the bronchiole is going to get collapsed, because bronchioles are not supported by cartilage. So this point where the bronchioles are getting collapsed, this point is known as dynamic compression of airways point. So this is known as the dynamic compression of airways, and that's why I told you that whenever you do a forceful expression, at the end of the forceful expression, one point will arise where the bronchioles, the smaller size bronchioles, are getting closed off. When this is happening throughout the lung, means all the bronchioles are closed, at this point the remaining volume which is still there inside this alveoli is nothing but residual volume. So what you are finding out from this discussion is that whenever a subject is doing a forceful expiration, there is constant compression on these bronchioles and bronchi. Bronchi are supported by cartilage, so that's why they are not going to get collapsed, but the bronchioles will go on compressed, and one point will appear when they will be completely closed off. This phenomena is known as dynamic compression of airways phenomena. Now I have to understand, after understanding this normal one, how this phenomena is going to change in case of emphysema patient. Right, how this phenomena is going to change in emphysematous patient. So now this condition, now this patient is emphysema patient. You know that emphysema patient, there will be dilatation of the airways, dilatation of the alveoli distal to the terminal bronchioles, right? So more and more dilatation of the alveoli, what will happen? Some of the alveoli will get ruptured. That is the main pathology of emphysema. So what I am saying, if this is an alveolus from this emphysema patient, the some of the alveoli in the lung will be ruptured, and whenever there is rupture, what will happen to this elastic tissue? Elastic tissue will also get destroyed, right? So destruction of the elastic tissue of some of the alveoli is the initiating point of chronic emphysema disease. So if this elastic tissue is destroyed, try to think that the subject is doing this forceful expiration. The subject is doing this forceful expiration. Emphysema patient is doing a forceful expiration. Think of the subject has taken a inspiration, full inspiration. Tell me, the inspiration will be easier in emphysema patient or not? What is the compliance of emphysema patient? Higher than normal or lower than normal? Higher than normal. I told you the compliance of emphysema patient is higher. So whenever the subject will take inspiration, the lungs will be hugely expanded because of high compliance. So inspiration is easy. I am writing like this. Inspiration is not that much problematic. I am writing that inspiration is easier and lungs will be hugely expanded. Oh my God. So you are thinking that this is good enough. No. Now the expiration should be passive, but in case of emphysema, this elastic recoil of this tissue is lost because of the rupture of this elastic tissue. So passive expiration is not going to happen in this emphysema patient. What the subject has to do, the subject has to apply some force from this chest wall, right? So the subject has to push from this chest wall, and then only the alveoli will be squeezed out and the expiration is possible. Getting my point? So the main problem of this emphysema patient is that due to rupture of this elastic tissue, the passive recoil during expiration is not going to happen. So the subject has to do some forceful expiration from this chest wall. So whenever the subject is doing or applying some force from chest wall, try to understand the previous phenomena. So suppose the external force is 25 millimeter of mercury, and this elastic recoil force, suppose that is 0, because the elastic tissue is destroyed. So the elastic recoiling force is 0 millimeter of mercury. So at the beginning of the inspiration, what is the total pressure inside this alveoli? That is 25 millimeter of mercury, or maybe a little higher than that of the 25 millimeter of mercury, depending on your elastic recoil tissue destruction, elastic recoil, right? So if the air is pushed with this 25 millimeter of mercury pressure, just now we have discussed that there will be drop of pressure during this pathway, and whenever this pressure drop is happening, I can understand that the outside pressure of these bronchioles is more than that of this inside pressure. So what will happen? Whenever the person will try to expire, immediately the bronchioles are going to get closed. So that's why we say that in case of emphysema patient, there will be collapse of bronchioles, at an early stage of expiration, early stage of expiration. Getting my point? So for a normal person also there will be collapse of bronchioles, but look at, for a normal person he will expire a certain volume of air, and then only at the end of this expiration there will be closure of these bronchioles. But what is happening in case of emphysema patient, due to loss of elastic tissue, whenever the person is starting this maneuver, immediately at the beginning of the maneuver there will be collapse of these bronchioles. So what will happen? We say that emphysema patient means there is early collapse. Now if there is early collapse, so when the problem is arising, inspiration or expiration, obviously the expiration is problematic. That's why I am saying that emphysema means it is under the category of obstructive disease. So how to remember obstructive disease? You have to remember like this, that obstruction during expiration, that there is obstruction of the airways during expiration, and this obstruction is occurring at the early stage of expiration. So if the subject is taking a deep inspiration, so huge amount of air will enter in the lung, I can understand, huge amount of air is entering in the lung during inspiration, but during expiration there is collapse. So very high volume of air is entering in the lung, but very less amount of air is going out of the lung. So most of the air is remaining inside this alveoli in a trapped condition, and that's why we say that there will be air trapping phenomena in case of emphysema. So more and more breathing the subject will take, more and more air will be trapped inside the lung. If more and more air is trapping, so what will happen to the residual volume of this person? Obviously it will be increased. What will happen to the total lung capacities of this person? The total lung capacities will also increase. That's why we say that obstructive disease means the prototype is the emphysema. The residual volume will be very, very high, as well as the total lung capacity will also be very, very high, and that is due to air trapping phenomena. Now imagine that a person is suffering from this emphysema for last 5 to 10 years. His total lung capacity is very, very high. So how the lung is going to accommodate this extra amount of air? Okay, how this lung is going to accommodate this extra amount of air? That is nothing but increase in anteroposterior diameter of the chest wall, right? So your lateral diameter is more normally, but whenever your lung volume and capacity is rising, total lung capacity is rising more and more, how the chest wall is going to accommodate that? There will be increase in anteroposterior diameter. So in this condition you can find out that due to increase in anteroposterior diameter, it is almost same to same with that of the lateral diameter, and under cross section you are finding out a barrel shaped cross section. This is known as barrel shaped chest, typically developed in case of emphysema patient and chronic emphysema patient, right? Okay, so this is barrel shaped chest. Now second thing, suppose I am suffering from emphysema for the last 5 to 10 years, okay, and I know, although I don't know the detailed mechanism, but somehow I came to know that if I try to expire forcefully, there is problem because of the closure. So how can I prevent this early closure, or how can I prevent this closure? If I give a positive pressure from here, suppose I am giving a positive pressure from this region, and that positive pressure is pushed inside this lung, okay, so I am giving a positive pressure is pushed inside this bronchiole, and what will happen? This positive pressure can open up these bronchioles here, and the expiration may continue for long time. So by some mechanism, if I give some positive pressure from this mouth, okay, so this is your mouth region, if you give positive pressure, it will enter inside these bronchioles and it will try to open up this closed bronchiole, so you can maintain your expiration for some long time. And that's why the subject will do an expiration by this kind of maneuver. So if I do like this, you are generating extra pressure inside your mouth, and by experience the emphysema patient knows that if he or she breathes like this, then the expiration is becoming easier, and this kind of expiration, all of you know that this is known as pursed lip expiration, where the subject is generating certain positive pressure from here, from this mouth, and that positive pressure is delivered at the level of small bronchioles, and it will open up the closed bronchioles, and the subject will maintain the expiration for a long time. So this way we all know that this pursed lip breathing is nothing but like a positive end expiratory pressure during expiration, and this way the emphysema patient will continue to expire. So this is the basic pathology of emphysema, that why the lung volumes and capacities will be higher, okay, and why there will be early collapse, right? Now if you look at the restrictive disease, here I told you that how to remember the restrictive disease. Okay, restrictive disease means restriction during inspiration. Think of the lung fibrosis patient. Okay, so I can understand like this, that this is the alveoli, and due to fibrosis these alveoli are becoming smaller in size, and it is becoming stiff, it is becoming hard. Not only at the level of parenchyma, this restriction can occur also at the level of this chest wall. Suppose I told you that myasthenia gravis, so these muscles are paralyzed, right? So you will not be able to take a full inspiratory maneuver. Or this chest wall, suppose this chest wall is becoming harder, like for example ankylosing spondylitis or kyphocoliosis, again there will be restriction during inspiration. So if this person is trying to take a deep inspiration, what will happen? The person will not be able to take deep inspiration because of the rigid lung, because of the hard lung. So that's why we say restrictive disease means restriction during mainly inspiratory phase of respiration, right? But if you are able to expand this lung a little bit, because the lung is harder, you know, this elastic recoiling of this lung will be very faster. Why? Because I told you that compliance of this person will be lesser, but compliance is inverse of elasticity. So what will happen to the elastic recoiling force of this lung who is suffering from fibrosis? Elastic recoiling force will be more. So there will be difficulty in inspiring, but after inspiration, when you release this lung during expiration, there will be rapid expiration. So expiration of this person will not that much problematic, it will be easier. That's why we say that restrictive disease means mainly the problem occurred during inspiration, and obstructive disease means main problem occurred during expiration. Now in these cases of restrictive disease, because the alveoli are getting smaller and smaller in size, what will happen to the residual volume of this person? Residual volume generally decreases if the restriction is at the level of pulmonary region. So this kind of lung fibrosis. But suppose the restriction is occurring at the level of this extraparenchymal region, maybe chest wall or maybe at the level of muscles. Suppose the condition of muscle paralysis, myasthenia gravis. If I ask you do a forceful expiration, will you be able to do a forceful expiration? Answer is no. So your force amount will be less. Less force means you will not be able to squeeze out the lung. So what will happen? More amount of air will remain even at the end of expiration. So that's why if the restriction is occurring at the level of this extraparenchymal tissue, then the residual volume will be increase rather than decrease. So residual volume may decrease, that is in case of fibrosis, or it may increase, that is in case of extraparenchymal restriction. But always in both of these, whether it is parenchymal or extraparenchymal, if you look at the total lung capacity, it will be always reduced, because the main problem is restriction during inspiration. So the person will not be able to take a deep inspiration, forceful inspiration. So that's why TLC is going to be reduced in this condition. So after understanding all of this disease condition, if I ask you, look at what will happen to the dynamic lung volumes and capacities in this disease condition, right? So I want to understand that how this recording, this dynamic lung volumes and capacities, how it will looks in case of obstructive and restrictive disease. So first you look at this normal recording. So this is the normal person recording, okay, dynamic lung volumes and capacities, right? I told you already, right? This is normal subject, okay. If I record this same maneuver from an emphysematous patient, okay, so inspiration, expiration, now I am asking the subject to take a deep inspiration, lung will be hugely expanded and the total lung capacity will be more than that of this normal person. Look at here, this is the total lung capacity of this normal person. In case of emphysema, the total lung capacity is high. But when the problem will arise? The problem will arise when the person will start expiration. So during this expiration, because of the early closure or collapse of the bronchiole, the person will not be able to expire completely and he will take long time for expiration. Even after full expiration, huge amount of volume will still remain in the lung. That's why we say that residual volume of this person will be higher than that of this normal person. Getting my point? So that's why in case of emphysematous patient, the curve will typically look like this, okay. So this is emphysema patient, okay. The expiratory portion will looks like a flat one, very flat one. It is taking long time. How it will looks in case of restrictive disease? So restrictive disease patient means if you do the same kind of maneuver, so starting from here, inspiration, expiration. Now if you ask the subject to take a deep inspiration, he will not be able to take deep inspiration. So the total lung capacity will be reduced than normal. But this expiration will be rapider and faster like this. Expiration will be rapider and faster. So this is the typical graph which you are going to find out in case of restrictive disease person. So this is restrictive disease person, right? So this kind of curve. So normal person, if this is the expiratory portion, obstructive disease patient means it will be very flat long time, but restrictive disease patient means it will take very short time, but the total lung capacity will be very reduced than normal. So now we look at this three curve that I have explained here, how it is given in books. So this is the curve which is given in books, right? So this is the normal curve, okay, and then you find out here the obstructive disease person and the curve from the restrictive disease person. Now if you calculate FVC, FEV1 and FEV2, how this value will changes in this disease condition, very important. So now we look at first the normal value. So FEV, that is the FEV1, because they are measuring the 1 second point. So this is FEV means this is nothing but FEV1. So FEV1 here is 4 liter, FVC is 5 liter. So if you take this ratio of FEV1 upon FVC, that is 80%, that is the normal. Now if I look at obstructive disease, he is taking long duration for expiration, so obviously FEV1 will reduce, and if you look at the total volume of expiration, that will also reduce because residual volume is very high. So in case of obstructive disease, FEV1 is also lesser, FVC is also lesser. What I am saying, please note down very carefully. Obstructive disease patient means the FEV1 will also reduce, FVC will also reduce. Both the volume will be reducing. But if you look at the reduction, so FEV1 is reducing much more than FVC reduction. Means you are taking a ratio. In this ratio, the denominator is not that much reduced, but the numerator is reducing to a very high level. So what will happen to the final ratio? The final ratio will be reduced. Getting my point? So look at the value. So it is decreased from 4 liter to 1.3 liter, very severe reduction. And FVC, it also reduced, but it is from 5 liter to 3.1 liter. So which one has been reduced more? I can find out that FEV1 has been reduced much more than FVC. So bottom line is that both the volume is lesser than normal, but if you take the ratio, the denominator is not that much reduced like that of the numerator. That's why the total ratio is less. But if I look at the restrictive disease here, again the FEV1 is also reduced, FVC is also lesser than normal. But if I look at FEV1 is reduced from 4 liter to 2.8 liter, not that much. But FVC has been reduced from 5 liter to only 3.1 liter. That means I can understand that in case of restrictive disease, FEV1, FVC, this FVC is much more reduced than FEV1, right? So what will happen in a ratio, if the denominator is reduced much more than numerator, then the ratio is going to be increased. That's why we say that typically in restrictive disease, particularly in case of parenchymal restriction, the ratio is increased, but in obstructive disease, the ratio is always decreased, right? But if you look as a volume of FEV1 and if you look as a volume of FVC, both the volume will be reduced in both the disease type, whether it is obstructive or restrictive. Both the volume will be reduced in both the disease condition, but obstructive means the FEV1 reduces much more than that of the FVC, and restrictive disease means FVC reduces much more than FEV1. That's why the ratio will be altered. So after discussing all these things, if you look at the difference between these two disease condition, all the lung function has been aggregate in this table, and this table is taken from Harrison's Principle of Internal Medicine books. Okay, so here the obstructive disease, the two obstructive disease prototype, that is the emphysema and asthma is given, and here is the restrictive disease, the parenchymal restriction, that is the lung fibrosis, and extraparenchymal restriction, that is the myasthenia gravis is given. So first you look at total lung capacity. We have already discussed that total lung capacity will be higher in case of emphysema, but it can be normal also, like for example in case of asthma. So obstructive disease means typically the total lung capacity will be higher, but it may be normal in early stage of disease, or it may be normal in case of asthma. Restrictive disease means total lung capacity must be reduced. Please note down, total lung capacity has to be reduced than normal. Getting my point? So if 100% is your normal, restrictive disease means it is reduced to 60%. Here extraparenchymal means reduced to 70% of the normal, right? Then you look at the residual volume. Residual volume always will be higher in case of obstructive disease. So this is also important. This is a diagnostic feature, right? That in case of obstructive disease, residual volume has to be increased. So in case of emphysema, it has increased to 310% of the 100% original, and in case of asthma, little higher, that is 120% of the normal, right? So if it is normal is 100%, then it is 120%. But in case of restrictive disease, I told you that the residual volume may be higher. That is in case of extraparenchymal restriction, because of the muscle weakness, the person is not able to expire forcefully, completely. That's why residual volume is higher. But typically, if there is lung fibrosis, then the residual volume will be smaller because of the size of the alveoli, smaller size of alveoli, right? Now, if you look at the volume, which volume? FEV1 as a separate volume, FVC as a separate volume. Both the volume will be reduced in both the disease condition. Both the volume is reduced. But look at which volume is reduced more. So if you look at here, in case of emphysema, FEV1 reduced to 35% of the normal, and FVC reduced to 60% of the normal. So I can easily understand that this FEV1, that is the numerator of the ratio, is much more reduced than that of the denominator of the ratio. That's why if you take the whole ratio, it is going to be reduced. But you look at the restrictive disease condition. So restrictive disease condition, there is again reduction in both the value. Both the value means there is reduction of FEV1 also, FVC also. FEV1 is also reduced, FVC is also reduced. But if you look at FEV1 is reduced more than FVC in case of parenchymal restriction, right? FEV1 is reduced more. Sorry, FVC is reduced more, that is 60% of the original, sorry. FVC is reduced more than that of the FEV1. That's why if the FVC is reduced more than that of the FEV1, what will happen? The ratio is going to be increased. Okay, it has reduced to 60% of the normal and the FEV1 is reduced to only 75% of the normal. But in case of extraparenchymal, both reduction are proportionate. That's why the ratio is remaining normal, or the ratio may be variable depending on the muscle weakness pattern, depending on the bony skeleton abnormality. So that's why it is said that ratio increased means, okay, it may be a normal person also, okay, or it may be a restrictive disease person also. You have to look at the other parameter like for FEV1 or FVC. Suppose you are getting a ratio which is greater than 80%, 84%. Will you say that the person is suffering from restrictive disease? Increased ratio is, suppose normal ratio is 80%, if it is 82%. First of all, you have to look at whether the person is normal or restrictive disease. How can I prove that is restrictive disease? You have to look at this FEV1 and FVC also. If both of this volume is reduced and then the ratio is increased, then that is restrictive disease. But suppose both the volume, FEV1 is also normal, FVC is also normal, ratio is little reduced, ratio is increased, then the person is normal person, right? So that's why calculation of this individual volume of FEV1 and FVC is also important along with the ratio. Right? Now look at what is written at the last of this table, AR. So this AR is nothing but airways resistance. Obstructive disease means there is collapse of the bronchioles. So there will be obviously increase in airways resistance, and you can find out emphysema patient means airway resistance is 1.5 times that of normal. Asthma patient means the airway resistance is much more than even emphysema also, because you know the asthma means hyper responsiveness of the airways. Okay, there will be hugely collapsed airways throughout the lung. That's why resistance is much more than that of the emphysema patient. But if you look at the restrictive disease, I told you restriction due to problem in parenchyma or at the level of extraparenchyma, not at the level of airways. That's why airways ratio is 1. 1 means this is nothing but normal ratio. Airways resistance is normal. Now if you look at the diffusion capacities of this lung, in case of emphysema, I told you the basic problem is that there is air trapping, and due to air trapping lung volume increases more and more, and then some of the alveoli will be ruptured. So whenever there is rupture of some of the alveoli, the surface area of diffusion will be reduced, and that's why there will be reduction in diffusion. So this is due to rupture of alveoli, reduction in the diffusion surface. In case of asthma, you know that here the diffusion capacity is increased than normal. Why there is increase in diffusion capacity in case of asthma? Right, this is due to hyperinflation of the lung. So please remember, this is due to hyperinflation of the lung. Due to bronchospasm, you know, during acute attack of asthma, due to bronchospasm, what will happen? The subject will take inspiration, but during expiration there will be bronchospasm. So more amount of air will remain in the lung, and due to hyperinflation of this lung, there will be increase in diffusion. That's why it is written in addition that diffusion capacities increase a little bit, right? But in case of restrictive disease, obviously if there is a lung fibrosis, the diffusion capacity will be decreased, and even the subject is not able to take deep inspiration also, muscle paralysis, then also the diffusion capacity will be reduced. So this is the various difference between obstructive disease and restrictive disease, right? Now we are going to discuss the modern spirometry recording that is a digital spirometer, how the recording looks in digital spirometer. So far whatever recording we have discussed, that is the recording in conventional spirometer, which is nothing but that water seal spirometer that we have discussed. Now if you look at the recording in the digital spirometer, this is a very simple apparatus. Here there is one mouthpiece. Inside this mouthpiece there will be a diaphragm like membrane, and that diaphragm like membrane is the sensor that can record the all volumes and capacities of the lung with this help of this sensor. So whenever the person is inhaling and exhaling through this mouth tube, what will happen? The recording will be shown on this computer screen. How this recording looks like, that we are going to discuss here. So digital spirometer recording rather than conventional spirometer recording, right? So we are going to discuss this recording of dynamic lung volumes and capacities, right? So this is the conventional recording. We have already seen that if the subject is taking inspiration, expiration, it will look like this, right? This is the expiration. Now same recording, how it looks at the level of digital spirometer, right? So look at, in the digital spirometer recording, you know, the y-axis is obviously the volume axis, but upward direction indicate this is nothing but expiratory phase, right? So in the conventional spirometer, we know upward means inspiratory direction and downward means expiratory direction. But here in case of digital spirometer, one recording is there where expiration is plotted in the upward direction. So when the subject is taking inspiration and expiration, suppose normal conventional spirometer, this is the onset of the expiration, point A. Then this is the middle part of the expiration, and the end of the expiration, suppose this is point C. How it looks in the digital spirometer, look at the diagram. Look at the diagram first, then I will discuss. Okay. So in digital spirometer, you are finding out that only the expiratory portion is plotted. This is the beginning point of the expiration, means this is the point A. Then almost this is the middle part of the expiration, and the end of expiration means this is the point C. So now you compare these two recording, how the recording is appearing in digital spirometer. Only the expiratory portion is recorded, and this expiratory portion, x-axis is obviously recording the time and y-axis is recording the expiratory volume. So if I measure this time, suppose the total time that the subject is taking for full expiration is 1, 2, 3, 4, 5 seconds. So within this 5 seconds, subject has expired fully. So what will be the name of this total volume that the subject has expired? This is nothing but FVC, right? If I want to measure what is the FEV1 from this recording, very simple. You drop one perpendicular from this 1 second point, and from there if you drop a perpendicular on y-axis, whatever volume you are getting here, that will be known as FEV1, right? So the advantage of this graph is that directly the expiratory portion is plotted, and the calculation of the FEV1 and FVC is very easier from this curve, right? So this is the first recording in digital spirometer. If you record the slope of this curve, this slope is known as PEF, peak expiratory flow rate. So this slope is measuring the flow rate. Why? Because we all know that slope is nothing but it will give you the idea of volume change with respect to time change. Flow volume upon time, that is flow, and this is nothing but peak expiratory flow rate. So look at how this diagram is given in Genome, right? So this is the diagram, I hope you have taken. Yes, so this is the diagram from Genome. Okay, digital spirometer recording, you can find out here. This is the FVC and this is the FEV1, and this is the onset of expiration, this is the middle part of expiration, and this is the end of expiration. Okay, this can be given as an image based question. Now the next part is that not only this expiratory portion curve, there is another curve also plotted in the digital spirometer parallelly, and that curve is known as the pressure volume loop. So now you look at another curve, different curve. So this is completely different curve where you are going to plot the flow along with lung volume. So x-axis is the volume axis and y-axis you are measuring the flow, right? Downward direction is the inspiratory flow, okay, so completely different, and upward direction is expiratory flow. Getting my point? So now you compare these two recording of the digital spirometer. Forget about the conventional spirometer. So on one side it is recording the simple expiratory portion, that is the FEV1 FVC calculation, and on the other side the x-axis is plotting the volume and y-axis is plotting the flow. But I have to remember that inspiratory portion will be recorded in the downward direction and expiratory portion will be recorded in the upward direction. This is according to the convention, right? And you also note down the number which is written on this x-axis, because the 0 is starting from this right side direction. This is maybe 1 liter, suppose this is 2 liter, this is 3 liter, this is 4 liter, this is 5 liter, suppose this is 5 liter, right? So the numbering is in the opposite direction also. Now in this curve I am going to plot a flow volume loop, right? How this is plotted? When you are asking the subject to do a normal inspiration, okay, so the subject is taking a normal inspiration, the curve will look like this. So this is the inspiratory curve. Inspiratory flow is plotted, so inspiratory flow will go on increasing, then inspiratory flow is decreasing. So this is the normal inspiration. Now if the subject is doing normal expiration, the curve will look like this, okay? So expiratory flow will rise and then the expiratory flow will decrease. So this is normal inspiration, expiration, inspiration, expiration. If I measure the volume during this normal inspiration and expiration, what is the name of this volume? If I ask you, tell me, during normal inspiration and expiration, the volume which is entering in your lung or the volume which is going out of your lung, what will be the name of this volume? So this is nothing but your tidal volume, right? Okay. Now you are asking the subject that you have to do a forceful inspiration, right? So now the subject is taking a forceful inspiration. So inspiratory flow is rising, flow is rising, flow is rising. So this is the inspiratory portion, flow is rising, then a peak is reached. After this peak, the inspiratory flow is decreasing, 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 and this is the end of inspiration. So now we look at when the person is doing inspiration, initially the inspiratory flow is rising, 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 then it is reaching a peak, and after this peak, inspiratory flow is decreasing, decreasing, decreasing. This is the end of inspiration. So if I ask you, at the end of inspiration, the total volume, which is approximately 5 liter here, what is this volume? What is the name of this volume which is present inside the lung at the end of inspiration? So this is nothing but TLC, right? Okay, so this is TLC. Now you are asking the subject that you have to do a forceful expiration as forcefully as possible, as rapidly as possible. So whenever the subject is doing a forceful expiration, the expiratory flow is rapidly rise to a very, very peak level. The expiratory flow is rapidly rising to a very high level. Then the expiratory flow is start decreasing. Why it is decreasing? Because of the phenomena of dynamic compression of airways. Getting my point? So because of the dynamic compression has been started in the lung during expiration, the flow rate will start decreasing, and if the person continue to maintain this forceful expiration, he will reach a point here. This is the end of forceful expiration. So at the end of forceful expiration, the volume which is still remaining inside your lung, if you measure this volume which is still remaining inside your lung, what is this volume? This is residual volume. Getting my point? So this point from here, if you measure the remaining volume, that is residual volume. Now again you are asking the subject, continue this forceful inspiration and expiration again. So again the subject is taking inspiration, 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 forceful inspiration. Again he is reaching at TLC. Again when the subject is doing forceful expiration, the curve will follow the same pattern like this. and again he will reach up here. So now you are finding out that if you follow this inspiration and expiration, it is forming a loop, and this loop is famously known as flow volume loop of respiratory system, right? In cardiovascular system we have discussed pressure volume loop, so here is a flow volume loop, very important, right? Flow volume loop of the respiratory system. So x-axis is the volume, y-axis is the flow. Now in this flow volume loop you have understood what is tidal volume. Now if I ask you that from this tidal volume point, if I measure the volume up to this TLC point, what is the name of this volume? So the extra volume which the subject is taking beyond this tidal volume, so obviously this is nothing but your inspiratory reserve volume. Getting my point? And if you measure this total volume means from this residual volume up to this TLC point, if you measure this total volume, this is combination of the multiple volume, this is nothing but your FVC, that is the forced vital capacity. So again you are getting multiple volumes and capacities from here, okay? And you can also get the expiratory reserve volume also. So now you look at this curve. So you are taking normal inspiration, right? Normal expiration, this volume is tidal volume. Deep inspiration, curve is going here. Deep expiration, curve is going here. Again deep inspiration, so the curve will go like this. If I measure this volume, this is nothing but my expiratory reserve volume. If I measure this volume, this is nothing but inspiratory reserve volume. If I measure this remaining volume, this is nothing but my residual volume. The peak inspiratory flow, if you look at from, this is known as peak inspiratory flow, and the peak of expiration is known as peak expiratory flow rate, right? Now I told you that you can also calculate this FVC, the total volume that the subject has expired. How to calculate that FVC? FVC is nothing but from here up to this level, this is nothing but my FVC. Now if you divide this FVC into 4 parts, 25%, 50%, 75%, 100%. So this is suppose 25%, okay? This is my FVC. I hope you are understanding. This is a 25%, right? This is 50%, right? This is 75%, and this is 100% of FVC. If I take the middle 50% of this FVC, so middle 50% means from this 25 up to this 75%, and if I measure the average flow rate during this period, this is known as maximum mid expiratory flow rate. Maximum mid expiratory flow rate, which is recently known as FEF, forced expiratory flow rate, from 25% to 75% of volume. Getting my point? So maximum mid expiratory flow rate is also known as FEF, 25 to 75%. How it is calculated? You divide this whole whole FVC into 4 quadrants: 25%, 50%, 75%, 100%. You calculate what is the average flow in the middle portion, that is 25 to 75%. That is known as FEF, 25 to 75%. Remember, this is a very sensitive indicator of early airways diseases, particularly the small airways. So what I'm saying, this is an indicator of early airway disease, right? Okay, particularly the small airways disease, very sensitive indicator of small airway diseases. Okay, early stage of disease also, this parameter will be different. In FEF 25 to 75%, the normal value is 300 liter per minute. Remember, this is in liter, I have calculated per minute. So it is generally taken into seconds, then it is plotted, it is expressed into minute. So in minute, if you express this, the value is 300 liter per minute. This is known as FEF 25 to 75%. So now you have understood the flow volume loop of the respiratory system, and the digital spirometer recording. All of you have understood. Now, if I try to think that how this flow volume loop is going to change in case of obstructive disease and restrictive disease, right? Because ultimately you have to diagnose your disease condition. So look at what will happen to this curve in obstructive and restrictive disease. So before going into this disease condition, this is the flow volume curve that I have taken from a book. So as you can find out here, multiple this inspiratory curve and multiple expiratory curve is given. But here it is given the diagram in such a way that all the expiratory curve is merging here in this portion. What is the meaning of that? Meaning is that suppose the subject is doing an expiration with lesser amount of force, then this kind of pattern will be seen. Then if the force is rising, then this pattern, that means peak expiratory flow rate is rising, peak expiratory flow rate is rising, right? So if I give more and more forces, what is happening? This left side portion of this curve, that is this PEFR, it is rising. Means PEFR is effort dependent, DEPENDENT. But if you look at this other part of that is right side of the curve, if you look at this part of the curve, then due to dynamic compression during this part, whatever force you apply, you are not going to change the flow during this expiratory, this end expiratory portion. That's why this right side portion of the curve, this is known as effort independent part. This is known as effort independent part. That means whatever is your effort, you are not going to rise the flow rate during the end of expiration because of the starting of dynamic compression, right? So this is the thing that you have to remember, that effort independent means at the end of expiration, the right hand portion of the curve is effort independent. That is due to dynamic compression. So now you tell me, if you think of emphysema patient, where you are going to get the problem during expiration. So whenever the person will start the expiration, the expiratory flow rate will be severely reduced. And that's why if you look at the emphysema curve, see here, okay. So first you look at this normal curve, okay. So normal curve, only the inspiratory portion is shown here, but you have to imagine that only the expiratory portion is shown here. You have to imagine that inspiratory portion is here. So this is my inspiratory portion, right? Okay. So you know that this is a normal curve. If you look at this emphysema curve or obstructive disease curve, you are finding out that inspiratory portion will look like this. And then you look at the expiratory portion, because it is the expiratory portion is going to be affected. So what you are finding out, this expiratory flow, this is peak flow rate, this peak is lesser than normal. Not only that, during this effort independent portion where the dynamic compression is starting, you are finding out that there is a severely depressed region at this part. Typically the curve looks like this, okay. Typically the curve looks like this, that there is severe decrease in expiratory flow. This is known as scooped out portion of the expiratory portion. This is known as SCOOPED, scooped out appearance of the expiratory curve. This is typical of obstructive disease of the airway. Getting my point? So if you are getting a curve like this, inspiration is smooth, then during expiration you are getting a scooped out appearance, okay. This scooped out appearance is the diagnostic of obstructive airway disease. Now we look at restrictive disease. I told you, if you follow this curve, so you are finding out that this is the inspiration and this is the end of inspiration. So here this is TLC. If you compare with the normal person, so this is the TLC of 6 liter. In this person the TLC is 4 liter. If you look at the residual volume, it is 1 liter. In normal person this is 1.5 liter. So residual volume is also lesser. TLC is also lesser, and the curve is looking like a narrow curve. This is very narrow curve, means the difference between this TLC and residual volume point is very close enough. Narrow curve is diagnostic of this restrictive disease, indicating TLC is not very high, TLC is very lesser. If you look at the TLC of this emphysema patient, this is 8.5 liter here, TLC, very high. But look at the restrictive disease, only 4 liter is the TLC, and the curve is narrow, but there is no scooped out in the expiratory portion, because I told you, due to elasticity, huge amount of elastic force of the fibrous tissue, the expiratory portion will be smooth like that of the normal person. But if I look at the residual volume, if I look at the TLC, and if I look at the whole appearance of the curve, this is narrow and it is restrictive disease person, right? But could you tell me what kind of restrictive disease we are talking about here, parenchymal or extraparenchymal? This is parenchymal restriction, because I can say, looking at this residual volume, so residual volume less means this is parenchymal restriction. But if it is extraparenchymal restriction, then the curve will look a different pattern. So look at here, again this is taken from addition only. So two restrictive disease you have to find out here. So this is the restrictive disease RP, that is the parenchymal restriction, and this is the restrictive disease E, that is the extraparenchymal. So RE is the extraparenchymal restriction, and RP, this is nothing but parenchymal restriction. So what you are finding out, in case of parenchymal restriction, I can find out that the residual volume is lesser than normal. But if I look at this extraparenchymal, then the residual volume is more than normal. But in both the person, if you look at the total lung capacity, so total lung capacity is reduced than that of the normal, because here is the normal TLC, here is the normal TLC. So you can find out that the TLC is reduced in both the condition, the TLC is reduced. But in one cases residual volume is higher than normal, but in other cases residual volume is lower than normal. This is nothing but restriction, parenchymal and extraparenchymal. If you look at the obstructive disease, so O here is the obstructive disease. If you look at this obstructive disease, TLC is very high, and you can easily find out this scooped out appearance. So this indicates that this is typical of obstructive airway diseases, right? By this way, by this digital spirometer recording, the flow volume loop recording, you can easily diagnose the lower airways diseases, whether it is obstructive or restrictive in nature. Now, I'll conclude this session with this flow volume loop abnormality in case of upper airways diseases. So if I plot this flow volume loop from a person who is suffering from restriction or obstruction at the upper airway means trachea, bronchus, major airways. So far we have discussed obstructive, restrictive disease, they are mainly in the lower airways disease. So upper airways obstruction, right? There are two types. One is fixed obstruction, right? And second one is variable obstruction, variable. So upper airways obstruction can be fixed obstruction, it can be variable. Variable obstruction, again it can be of two types. Variable intrathoracic, extrathoracic obstruction, extrathoracic obstruction, and variable intrathoracic obstruction, variable intrathoracic obstruction, right? So I am explaining what is the meaning of this. If the obstruction, fixed obstruction, means this will affect both your inspiratory phase of respiration as well as expiratory phase of respirations. So if an obstruction is here at the level of trachea, suppose there is a stricture of this trachea, suppose there is a tumor which is obstructing your inspiration as well as obstructing your expiration, then that is known as fixed. Fixed means both inspiration and expiration are problem, both affecting the inspiration as well as expiration, right? But variable means either inspiration will be affected or expiration will be affected. Variable extrathoracic means here the inspiration will be affected and variable intrathoracic means here the expiration will be affected rather than inspiration. I will explain why so, but just remember variable extrathoracic means inspiration is the problem and variable intrathoracic means expiration is the problem. So now we look at the curve first. So this is the normal flow volume loop taken from Harrison. I have already explained multiple times. Smooth inspiration and smooth expiration. There is no scooped out appearance. There is no box shaped appearance. Now we look at the fixed upper airways obstruction. So the example is foreign body in the trachea, scarring of the airways or enlarged thyroid gland. Obviously, I can understand it is going to affect my inspiration as well as expiration. So if I plot a flow volume curve, rather than the smooth appearance of this inspiration, rather than the smooth appearance of this expiration, what you are getting a box shaped curve. There is a plateau in the inspiratory portion also, there is a plateau in the expiratory portion also. The curve is looking like a box. So this kind of box shaped appearance is diagnostic of fixed upper airways obstruction, right? Inspiration, expiration both are affected. Now variable obstruction, variable extrathoracic obstruction. So if this is your trachea dividing into major bronchus and this is my thoracic cavity, so look at the thoracic inlet, right? If the obstruction is above this thoracic inlet, then this is known as extrathoracic obstruction, and that is variable, means it is going to affect either inspiration or expiration. Now we look at how it is happening. So look at the example: paralysis of the vocal cord, enlarged lymph node, flabby pharyngeal muscles. So your pharyngeal muscles are flabby. So if the person is taking an inspiration, there will be expansion of this thoracic cavity. There will be more negative pressure inside this thoracic cavity. That negative pressure will try to suck the air from the atmosphere. Whenever it is trying to suck air from the atmosphere, if the muscles are flabby, if the muscles are soft at the level of this trachea or bronchus, what will happen? They will enter inside these airways. So what will happen? These flabby muscles will going to cause or is going to causes obstruction whenever the person is trying to take inspiration. So this vocal cord, paralysis vocal cord, or maybe this pharyngeal muscle, they will be sucked inside these airways, and that's why which phase of respiration will be affected? Inspiration. When the subject will do the expiration, because he is pushing air through this airways, what will happen? There will be expansion of this airways and this obstruction will be removed. So now you can understand that variable extrathoracic obstruction means inspiratory portion is going to be affected. So this smooth inspiratory portion will be lost. There will be flatness of inspiratory portion, but if you look at the expiratory portion, this is like normal, right? So this is variable extrathoracic. And variable intrathoracic obstruction, now it will be easier for you to imagine. So this is dividing, and look at the thoracic cavity and thoracic inlet. So if the obstruction is here, right, most commonly the tracheomalacia or by tumor. Suppose there is a tumor here at the intrathoracic portion. If the subject is taking inspiration, there will be dilatation of these airways. So this tumor blockage will be lesser. But whenever the person will do expiration, there will be compression of these airways. Tumor will block more. So variable intrathoracic means expiratory portion is going to be affected. That's why you can find out there is flatness in the expiratory portion of the curve, but smooth intra or inspiratory portion. That's why you will get this kind of appearance in variable intrathoracic obstruction, right? So this is all about your lung volumes and capacities, basically lung function test.